And the next speaker will be on another modality or types of governance that will be presented to us by Professor Ammar Siamwalla. Just by coincidence that this morning I drove from my house here, listening to the national radio Thailand. And he was, he released his message through the national television about his disappointment of the agricultural pricing and some sort of popularity scheme of the previous government. So now he will be presenting about market on health, but not on agriculture. We will be pleased to learn. We will be happy to learn from him. Professor Ammar, please.
Thank you. Thank you, sir. Professor Wiwat, let me hasten to add that what I say about rice markets do not pertain to health markets. Okay, they are very different, and let me get on to. And I think the Thai government got it all wrong. They want to govern the rice markets, and they want to have the markets govern the health markets. Anyway, I think the nice thing about governance, as Professor Wiwat has discovered on the morning of his presentation some time back, is that it's a do-it-yourself definition. You can make it do what you want. My definition of governance for the purpose of this, I don't say that it is the definition, but for the purpose of the discussion of my presentation, is that is the system whereby resources are allocated, health resources are allocated, so that the resources are human resources most importantly, but also physical resources, hospital beds, X-ray machines, whatever, are allocated so that it solves the health problems of the people in general. And so that's the concept of the system whereby all these things get allocated. So an economist have a system. We forgot about the network of Professor Surichai Wan-kaew. And that is, you can have the resources be allocated by markets and resources be allocated by command and control, usually by the state, but there are command and control possible at different levels, okay, as Professor Vinai has pointed out. So that divides the two into two discussions. You can have governments by markets, and you can have governance of the markets. Because unlike most economists, I believe that every market, even the stock market, has to be governed. There have to be rules set out, there have to be, and so on and so forth, which we can discuss at length. But governance by markets means that decisions are made by different parties other than the government, and they govern by means of money, basically, but by financing and so on, by paying for it. And then the issue that we have to look at when things are governed that way is whether the markets are competitive, whether the markets are fair market, and so on and so forth. In Thailand, the governance by markets is not this even across the whole health system. Different health insurance system that we have, the three big health insurance system that we have, the non-health insurance, i.e. the out-of-payment pocket, out of insurance, shall we say, out-of-pocket payments. These are very much market-driven. People go to see the doctor, and they pay for the doctors, and they stay with the doctors or move the doctors according to whether the doctors cure the problem that they have. And therein also lies already a lot of problem. And in Thailand, we have this out-of-pocket sector, which is important, and the foreign sector, okay, is the market is fully operative. There is very little price control. There are regulations and so on to deal with sanitation of healthcare facilities and so on, but it's minimal. And the labor markets for health personnel also is fully is somewhat unregulated, okay, and that's important because it's a linkage between the out-of-pocket sectors and also the foreign sector to the insured sector. And this is the first point I want to make about governance by markets. In the insurance sector, the three insurance sectors, there are semi-operative. The social insurance and to a very limited extent the NHSO also, they purchase, okay, the services of the private hospitals to supplement the public hospital sector, and they also purchase from the public hospital, and so you have the private hospitals being also involved in the insured sector, and the Social Security Office have to pay what the private hospitals demand. And that there is a lot of bargaining going on at that level, but in the end they purchase. And as time develops, there is a very interesting kind of, if you look at the time series of private hospital participation, you see a kind of sawtooth effect because the Social Security Office, being a bureaucracy, takes time to adjust the price it pays. So it will raise the price that it pays to the private hospitals from time to time, but between the first time and the next time, inflation erodes that payment, and there is a departure until there is a crisis. All the poor patients of the SSO are then dumped into the public hospitals. The public hospitals are bound to provide services for both NHSO and Social Security Office by a cabinet decision. So they have no option. Certainly the public hospitals in the Ministry of Public Health. Those of you who are foreigners will find this very complicated, but that's the way life is in Thailand. There is no, as somebody pointed out, there is no system governance. There's governance of this, governance of that, and governance of everything. But there is nothing that looks at the entire system. In the case of NHSO and MOPH, the role of markets in any sense is very limited. It's almost entirely a command and control system. People are assigned to different providers, and they have relatively little choice, particularly in the rural areas, because they are usually assigned by the NHSO to MOPH, the Public Health Ministry hospitals. And it's very difficult to avoid that. And even though there are many private hospitals who claim they are willing to enter the thing, but on some conditions which the Ministry of Public Health find unacceptable. So it's the 30 baht scheme, the so-called UC scheme. By the way, for foreigners, universal healthcare doesn't mean universal. It's, in a sense, the best way to describe it is it's a universalizing healthcare. Essentially, we have three systems, one for civil servants, and of course civil servants have the Cadillac of the system. It's a fee-for-service system. It provides the most expensive healthcare in Thailand, quite inefficient. But from the point of view of the users, of the patients, they consider it to be the best. Most doctors, including doctors from the Ministry of Public Health, use the civil service benefit scheme because they have an option to do that. And that shows that despite the propaganda that it's expensive and so on, when it comes to their own health care, they go to the civil service benefit scheme. Anyway, the problem with the ministry, the NHSO scheme, is that it's very much dependent on a command and control. Most of the public hospitals have no choice in not accepting. I should say public hospitals in the Ministry of Public Health. There are many here from the teaching hospitals. They can get off. Okay, they sometimes don't accept, and in fact, it's unavoidable that they have to get off, because given that it's free everywhere equally, okay, everybody would want to go to teaching hospitals, which have the world's, no, not the world's, but Thailand's best doctors, including two who are on this panel. Okay, and so it's compulsory. Now, all this kind of system, mixed system, okay, with no clear overall governance, has a problem. Governance by markets of the system, of the place where it works, where it's operative. Within, for example, the out-of-pocket and the foreign sector, we have the world's fanciest hospitals. It's almost obscene because we have 5-star hospitals. It's probably the only country in the world that have 5-star hospitals. But and they are the best. Okay, and also for civil servants, which use fee-for-service, which is semi-market, they get to choose where they go, they get to choose where they use the facilities, and so on and so forth. They also get very good. All of this burden make for a very lopsided healthcare system. Over time, the UC scheme has become, how can I, where can I, the best word I can find is an English word, which for Thais is difficult, is ghettoized into they are dumped into a slum of facilities for the poor. Mind you, the system works because there is a lot of hospitals, a lot of hospital administrators, a lot of doctors who care for their charge, even though they have to work very hard. But the problem becomes that the quality of that services have steadily deteriorated. Okay, and I mean, the universal healthcare problem has solved the access problem beautifully. Okay, but it's access to what? And over time, the health insurance system is becoming unsustainable. The OOP payment by the market, okay, by people like me, we pay for our services, and we get to choose where we go, okay, and on top of that, we have this medical hub nonsense that the government is trying to foist on Thailand. It's not really the government. The government has done very little. But hospitals have found that by bidding some of the best doctors in Thailand away from the public system, okay, they are able to provide best services for foreigners. And what happens to the system is that the price or the salaries of doctors have been slowly inching up. The state system, which is again very slow to adapt, have increased wages, but not at the same speed. And doctors have been migrating out of the public system into the private system. The public system is being squeezed for resources, and in the long run, and also the budget is squeezing the public system as well as NHSO, which is in charge of mobilizing and allocating the resources to be used in the 30 baht scheme. So I believe that over time, if the market in healthcare, in the sectors that remain where the markets predominate, is not in any ways regulated, the system of health insurance, particularly the UC system, cannot be sustainable. And this is the markets have to be governed. It can't run rampant. Okay, so with that, I have proven my point that rice should not be regulated, but healthcare should be.
Thank you very much. Thank you. The floor is now open, but thank you very much for the three presenters. I observed one thing that we advise them to present only 10 minutes, but none of them adhere to that. But anyway, it's okay. Now the floor is open. You just raise your hand, then microphone will automatically go to your hand. So please introduce yourself and then comment or ask question. So the microphone is not switched on, but anyway, we hear you.
I think probably can we park that question because as you can see in the program there is another 2-3 presentation which will look into governance by network and where probably this question would be relevant. Professor Anand.
Thank you very much. Professor Ammar, I was really interested by your talk and its sort of very strong logic. On the other hand, price regulation is not something that governments find easy to administer, even in the health sector, as long as you have, as you describe, this combination of the dynamics of the private market and then the much more state-regulated section. And I wondered if you could go a bit further in reflecting, I mean, your first statement there, markets that dominate certain sectors must be regulated. What sort of measures would you like to see in place? Would that be, for example, price regulation of this private out-of-pocket payment, private insurance, private hospital sector, or do you see other ways of achieving that regulation?
I think I exaggerate a little bit when I say that the labor market, for example, is unregulated, or the well, certainly the foreign sector is unregulated, but the labor market is not completely unregulated. It costs 2 million baht plus a little bit to produce a doctor. This is something that is I'm going to say that we're very unpopular with doctors. And at the moment, the state requires doctors to perform, to work for the state system for 2 years, or they can get off that requirement. 2 years, is it? 3 years now. 3 years. They can get off that regulation by paying 400,000? Yeah. 400,000 baht. Quite a long distance away from 2 million baht. And most of the private hospitals are being subsidized in their ability to obtain physician services by a huge amount. And with that, they have been able to offer very competitive prices to foreign patients. I'm focusing on foreign patients because it's the most egregious of the misallocation. At the time when Thai, I don't want to be nationalist about it, but people around in the region who sometimes use our services are being shortchanged a great deal. So I proposed very mild regulation, which is far from solving the problem, a tax on billing, on the billing on foreign patients of 10%, 20%, whatever. And I think we still could be competitive. Okay? And use that, for example, to expand the ability to produce doctors of teaching hospitals. the biggest objection that I hear are usually from the teaching hospitals. Because most, again, I'm sorry to step on people's toes, but the teaching hospitals, most professors have moonlight at private hospitals, and private hospitals don't waste their time with new graduates. They go for those who have gone for specialist training and so on. I mean, this is one example of the misallocation. There is, I mean, the Ministry of Public Health has failed miserably in its role as system governance and everything. It doesn't do anything about the production of new doctors. It has absolutely no control, because production of doctors take place in the Ministry of Education. Okay, and so there is no system governance in Thailand. Okay, either by markets or by command and control. So there are lots of misallocations that arise out of very aggressive market mechanism in the OOP, out-of-pocket system, and in fact, another thing that I have not dared to propose is the OOP users should be paying at least VAT. At the moment, it's free of VAT, because that would create quite a ruckus. But if you don't control all these, I mean, by much harsher systems than, I don't think price control would work. Although I think I love this new invention that I come across when I got into this business, is the DRG system. You can have a price control on that, of the price of the use of the inpatient department, because it is becoming more and more of a racket in the private hospitals. I use the private hospitals, and I have become a refugee. Well, Thai patients have three options when they want to use the medical service. A, they can use money. B, they can use connections. Okay, that helps a lot, particularly if you want to use, again, I keep coming back to teaching hospitals. And C, if you have neither, you can spend a lot of time. You just wait all day. Fun. And in emergency, you can wait until you die. Okay, so it's a very unfair system. On the surface, it looks beautiful. We are the talk of the world as to how great our system is, but it's falling apart, and it's falling apart very rapidly. Thank you.
Okay, and I have some disagreement with him, but I am not a presenter, so I cannot open my mouth. But anyway, next question, next comment, please.
If I am allowed to ask
yeah.
after the participant.
Unfair. You are speakers, and then you are asking questions also. Yeah.
Do you allow me or not?
Okay, please go ahead.
So it's fair.
Yeah.
The discussion seems to focus on the level of macro policy changes, which seem to me at the moment we are entering into the darkness, no way out. Why why can we just take into account the meso-level changes? Let's give you some example why I care about the changes at this level. There is a border hospital in Umpang, the Burmese border. The director of that hospital sacrificed himself to do the job that nobody wants to do. That is to provide care for the refugee, no money. And he needs to live on the budget from the government, whatever the sources, and also donation from other sources, which he has been struggled a lot. And this it serves as a good example of meso-level governance system. But the question for me is, do we have a way out of designing a better governance system at that level, actually in relation to the macro policy level and the micro system as well? Thank you.
In relation to that, my question probably to all the speakers is, how about what is the role of government to, there is a maldistribution of the private or the market sector. It tends to be more in the centers, in cities, and especially in the case of Thailand, in Bangkok. What's the role of governments in encouraging the private sector to go into where access is minimum? How is that used in the case of Thailand, for example, as a foreigner? I see that. And how much, when we say the government is subsidizing the market, how much is that in terms of volume? Because how much are we talking about? Is it really which would break the bank, or is it more symbolic? Maybe that's why, for example, in Umpon, and I talked with the director, the same in Mission, is they rely on the government's universal health coverage to subsidize the service they provide to the migrants, which required the government to look into additional security financing system, which is currently being discussed. How do you see that? How do you see that role of the government versus the market? Thank you.
Please respond very briefly, please. You have a break in 5 minutes.
Okay. I think there are questions to me, right? With the Umpang and border areas, actually, this is to my shame as well. I used to be the chairman of the finance committee of NHSO, and every time this problem comes up, and every time it's very difficult for us to allocate funds for the people who are not Thai citizens. And our Ministry of Interior have this, let me be frank about it, very stupid policy of excluding people who have been here for years, close, and I think some of them have been here for longer than the ancestors of some of the ministry officials. And they've been here a long time. So they cannot, and the law says we have to give this to Thais. We try very hard. I mean, I'm sure that if the NHSO has been smart enough at the beginning and not asked the juridical council for a view on it, we would have gotten away with, okay, I noticed that in your paper you said the rule of law is very low in this. So the rule of law sometimes is not always a good thing, because we stick to the rule of law and we cannot obtain budgets to take care of these people. And the director of Umpang has to be commended. He works very hard. He works around the clock to raise funds. One lucky point is that, like in most developed countries in the past, charity, giving money to hospitals and to sick people has been a strong absorber of money, of charity money. Much of it goes to undeserved groups like Ramatibadi Hospital and Sirirat Hospital, which are extremely rich. They have money coming out of their ears. Am I right, Dr. Paiboon? But anyway, I'm half joking. It's money well spent. But I think there are some hospitals who subsist on having good connections with the abbot of the local temple, particularly if he's a well-known abbot who can raise a lot of money. So there are lots of other channels, private networks. Okay, the first thing most director of hospitals in rural areas do is to go visit the local abbot. Okay. Finally, your point about rural hospitals and why private hospitals don't invest in rural areas. Thailand has a relatively good presence in rural areas. In fact, the 30 baht scheme would never get off the ground if we haven't had an excellent rural hospital system. At the moment, the biggest problem with the 30 baht scheme is the facilities in the provincial towns. Another thing that I'm very upset by the Ministry of Public Health is, given the congestion at the hospitals, Thais have now got into the habit. If they have a cold, they go to a hospital. Okay, which never happens in Britain, for example. You go to a doctor, a physician. Okay, and they talked a lot about having primary health care, but they haven't done anything in the urban areas. The rural hospitals are natural places for primary health care, but the urban areas are quite underserved. Okay, so you have huge congestion in the local hospitals, in the provincial hospitals in the provincial town, and there the private sector are present. Okay, except that the NHSO refuse to send patients there. Okay, send the people there, because that will undermine the nice income that MOPH hospitals get. It's complicated, but we could use some of their facilities in that. But there are lots of problems about governance of money in the command and control system. And those problems are coming home to roost in this grand dispute between the Ministry of Public Health and the NHSO. Thank you.
So how about Professor Surichai, please?
The last word, he used the word grand dispute. It is not so grand, in fact. The grand challenge is how can government, your question, respond to the complexity of the issue of migrant workers. We have special economic zone, and method is to be announced even higher in terms of a self-governing body of urban area. But the point is that the policy coordination, to say the least, is very poor among ministries. The issue of industrial promotion is not at all linked to the issue of responsibility to the issue of the health of the labor. In this case, many are migrant workers. So there are no relationship of working mechanism between the Ministry of Labor. So the question asked about government, there is, to follow my senior professor, there is no government here. So we need a government that is really working together to respond to the challenges of labor demand that make Thai economy existing and going forward. So in that sense, I think we need a interdepartmental, interministerial level at least, policy strategy to deal with all these issues. So now we seem to be very reactive, have been so much reactive toward this issue, and much burden are on the budget of Ministry of Health. That is true. But why cannot we see this issue as a at least multi-ministerial challenge? And also, if we look beyond government, we see also temples, we see also civil society, which have been also supportive. So if we see on that level, we need a policy development along this line to be more, to go beyond reactive mode.
Dr. Vinai, you had anything to add?
Yes, thank you. Actually, I'm a doctor in the rural area, and what we have done, I can say like this: we follow the policy of the public health, but we follow the money of the NHO, and then we combine everything in the society. So you can see the example of the even not only the Umpang hospital. I think even in the rural area hospital, community hospital, we have done like that. So we try to integrate everything. Actually, my responsibility and the task there will be the primary care, but we can do the tertiary and secondary care as well in some area. And what about the private market? We try to look, not even the private market, we try to look at the local government. You can see that local government will be another source of finance. So we can combine everything in the area that we live in. Thank you very much.
Thank you very much. Why don't we stop for, let's say, 10 minutes for tea, coffee, and then we come back in 10 minutes, please. Thank you very much.
Just an announcement that the coffee break, if you leave the room, you just turn left. The coffee break will be served over there.